to this Our World AIDS Day panel discussion on HIV and allyship. My name's Tom Doyle. I'm the Chief Executive of Yorkshire MESMAC, and we deliver HIV prevention and social support services across West, South Yorkshire, and also in the Humber. Before I start and introduce our esteemed panel, I think it may be useful just for us to define what we mean by allyship. And in this context, we're defining allyship as someone who maybe isn't part or a member of a marginalised community, but wants to support that community, and more importantly, wants to take action to improve the lives of folk in that community. So that's me with my introductions. I'm going to ask the panel members to introduce themselves, and I'm going to go in the order as you appear on my screen. So Kieran, could you tell us something about yourself?
Okay, so I'm Kieran. I'm the lead nurse at the Bradford HIV service. I've worked there for the last nearly 3 months now, and so I'm new to the service at Bradford, but I've come from another HIV service in Bristol, and I've worked in HIV for 25 years maybe, so quite a long time. And my dim and distant past, I was actually a sessional outreach worker for Yorkshire MESMAC as well. So I have quite a bit of experience.
Fantastic. Amy.
Hello, I'm Amy Evans. I'm a consultant in sexual health and HIV here at Leeds Teaching Hospitals and at Leeds Sexual Health. I've been in Leeds since about 2000, been in HIV since about 96. Thankfully, I think witnessed so many of the improvements in HIV treatment and prevention and PrEP, but also so aware on World AIDS Day about us remembering the people we've lost as well, and this important time of memorial and celebration.
Great, thank you. Ben.
Hello, I'm Ben Musanzi. I'm from Bradford. I'm the chairman, if we could say that. In French we say president, but in English it's chairman. I'm chairman for CRC, Centre Résolution Conflit, which is in English Conflict Resolution Center, based both in the Congo and in the UK, here in Bradford. My role is, apart from being the chair, awareness raising strategist for anything related to conflict, including environment and HIV and so on.
Great, thank you. Clement?
Good afternoon. My name is Clement Katulush. I've been involved with HIV and AIDS awareness for the past, 30 years. From Zambia, where I used to work with the Salvation Army Mission Hospital, going through the first cases of HIV/AIDS in Zambia, to my coming here into the UK and working within community development as a peer health educator within the African communities, subsequently as a project manager for ABCD based in Leeds, in Bradford. Had the pleasure of actually working with some of you. Currently, I'm the resident pastor supporting 2 churches here in Leeds, and also a year 3 project supervisor for Formation College. Pleased to see all of you again.
Great. Well, welcome everyone. I think Amy was right in terms of today is World AIDS Day, and we're entering the 5th decade from when the world knowingly knew that we were collectively living with HIV as a world. And I'm curious, from your different perspectives, what you see as the major developments of HIV over the past 40 years. Clement, would you like to start with it?
I think in terms of medication, there's been leaps and bounds, but not as I would love to say it, but must acknowledge it, that it's happened, it's taken place. What used to be, I would say, a death sentence is no longer a death sentence. And I think that's great news for us to celebrate and acknowledge on WAD World AIDS Day.
Great, thank you. Kieran, what about you and your 30 years experience on the front line?
Yeah, I think there's been a huge change from when I started, when the very first ward I worked on, people came in very, very ill and weren't expected to live for very long. And now we're at a point now where we consider HIV to be very much a chronic illness, very much like diabetes or even hypertension, that it's it's controllable over the long term. People are living with HIV, and not just living with it, but living healthily and having a good quality of life. And I think one of the major things for me has been the U equals U, undetectable equals untransmissible. That if somebody has a undetectable HIV viral load, that they cannot transmit the virus to their sexual partners. And I think that's been a massive game changer for a lot of the people that I've looked after.
So one of the questions we're often asked around U equals U is, how do you get to be you? How do you get to be undetectable?
So basically that's by, for the vast majority of people, that's by taking an antiretroviral treatment. So treatment to control the HIV life cycle so that it's no longer able to replicate. If it's no longer able to replicate, when we do blood tests, we're actually able to measure the amount of virus in the bloodstream. And so when it's undetectable, it means that our blood tests cannot pick up any virus in the bloodstream. We know that if somebody stops taking treatment, the viral would become detectable again. So we can't class being on treatment as being a cure. We can control it and keep the viral load undetectable. So that's how people would achieve that undetectable status.
Great, thank you. Ben, what are your thoughts on where we've been in the last 40 years?
In comparison to what HIV was in 1980s, when it was really the case in Africa, particularly in the Congo, where I am originally from, where there was lots of conflict related to that, because anybody diagnosed with HIV was just thrown away or not looked after. But today things have changed. People are slowly understanding that you can't catch it just like that, because at the past, people thought that just sitting next to somebody with HIV, you'll get it. And then this is what was really creating conflict. But today things have changed. People are aware of what it is exactly. And that is good development. Apart from that, I could say that the problem still remain there, particularly in Africa, in terms of medication. There are areas where you, of course, in the country like mine, originally I'm from there, but originally, just as it was in the past, today it's still the same. People don't have access to medication. This medication we take for granted here, out there it's not the case.
Yeah, sure. Amy, what's your thoughts?
I absolutely echo what people have said already. I think the transformation in HIV treatment, to hopefully for many people what might be once a day pills, and maybe one pill once a day, from the old days of when I was a junior doctor, and it really was 3-4 times a day, 16 pills with grapefruit juice, not with grapefruit juice, having eaten, absolutely revolutionised. Still not possible for everyone, or indeed, as Ben says, not everyone has access to it. I think in terms of injectables, such a promise with those, a real holy grail to think that, and I look after young people and teenagers as well, and you can imagine for children, for so many people, the idea I might have an injection. I think we're not quite there yet. We've only got 2 medicines available and you have to have them fairly frequently. But actually, does that indicate that the drug companies will only increase that? So you can imagine, actually, if we could get injections which might last 6 months, a year, more than a year, you might combine it with your contraception if you're a woman. You know, and can you imagine as a teenager living with HIV to have that done in one shot? I mean, that is fantastic. So I think that holds such promise, I think, for people going forward. And I think PrEP, you know, prevention, real prevention, the game changer for us in terms of prevention, I think, as well as rapid testing and access to treatment, has been preventative medicines taken in advance of risk. Absolute game changer. And we've seen new HIV infections, haven't we, fall off a cliff in those groups who are aware of it and access it well, and including in Leeds. And we need to make sure that's widely available.
Sure. Can you just explain to the folk who are watching what PrEP stands for and how it works?
Yes, sure. So HIV PrEP is pre-exposure prophylaxis, which is a bit of a mouthful. The jargon means preventative treatment. And the pre bit of PrEP means I'm taking this before being at risk. So that might be sex for most people. And it might be sex with a partner who's not on treatment yet, or is maybe going through a tough time and not managing their tablets well at the moment, or they're poorly. And haven't been able to take their treatment. So their viral load, as we were talking about earlier, might have come up. So in that instance, they're not U equals U, and it might therefore be at risk of passing on. And also for people who maybe the partners they're having sexual contact with don't know their status and maybe don't know if they're positive or negative, but they might fall into a higher risk group. Being from a country which has higher levels of perhaps adult HIV, or being from a community like the LGBTQ plus community, which may have higher levels of HIV, which somebody may or may not know about. So by taking PrEP tablet oneself, that's the ability to protect yourself when others may not know their status. Which I think can really add to that level of confidence about, okay, I may or may not be able to use a condom or negotiate condom use, but actually I can do something else which gives me that added protection.
Great, that's really useful. And one thing we talked about has been this really steep decrease in new infections around HIV, but that decrease isn't even across all community groups. So we know that folk from Africa, particularly African women and some South Asian men, are not seeing the same levels of decrease of HIV infection. And I'm curious, perhaps Ben could comment on what could we perhaps do to reach out to those communities, to reduce barriers to those communities so that no one's left behind in terms of HIV prevention?
Is it me you are talking to?
Yes, please, Ben. Yeah.
Okay. I think more awareness raising will be very important, because as you say, in medical domain, medical field, you say that prevention is better than treatment. So that is crucial, and I think that is where we could put all our energies, to even funding, if it's possible, to raise awareness of people, not only to wait around the 1st of December. It's something we have to do regularly. When Amy was talking, there is something which came in my mind. Mary, sorry, we are in meeting. What came in my mind when Amy was talking was BBC came with an article in, if my memory is correct, 2013, and the title was "Sex Workers Using Anti-HIV Drugs Instead of Condoms." Is it the same thing you were talking about when you speak about PrEP tablets?
I suspect it's a development on from that, Ben. There were a number of different trials done over time for people who were being regularly exposed to HIV.
Yes.
To see what could give them, you know, a real benefit. And a number of trials have been done with a number of different agents across the world. But in more recent years, actually, we've had some very, very good safety and data showing they work very well in a simple pill taken once a day. That's the most common form of PrEP available worldwide. There are still different ones available. There's an injection being looked at. There's other types of pill. But what we've seen is actually in many countries, they've adopted that pill being available within their healthcare systems. And of course, many people, of course, are paying for it themselves. And in the UK, it took activists really, particularly in the LGBTQ plus communities, who linked together with medics, I think, to say that this should be available. The data on it is really compelling. Who got the GMC to say, yes, we think doctors should support people to do this, and put pressure on the NHS to then supply it. And we initially got a trial, and now that's part of NHS free availability, if that's indicated, currently just through sexual health clinics. But again, we're really hoping that may widen out. And it's so important to get that message out there that that's now a safe, very, we hope, available and well-tolerated treatment. And we need to get that message out to more people.
I'm happy to learn that, because because when this came into my mind when you were talking. Thank you. So as I was saying, really, prevention. If we could put more effort on that. Yes.
Yeah, sure. Clement, do you have any thoughts how we can make sure no one's left behind?
I want to agree with what Ben has said about prevention. And I think over the years, what worked was raising a lot of awareness around the fears surrounding HIV/AIDS. I was just trying to keep update with events in Africa, in Zambia in particular, and I think there was concern that rates are increasing in Zambia. And that's a bit alarming. Although they're making the right kind of noises, saying it's possible, just as we have done with COVID-19, we can also get the same kind of uptake in terms of HIV and AIDS services that are available in the country. I think in the UK, much inroads have been made owing a lot to the activism that's taken place and the vigilance of the LGBT community. I think they've pioneered much of that activism. And it seems to me at the moment that that's flagged down a bit, that there's a little bit of fatigue within most of the countries around in terms of HIV/AIDS awareness, waiting for 1st December. I want to echo that it's not really adequate. We need to have an ongoing heightened awareness around dealing with especially stigma that still exists. I think also the fact that in most of the cases we still have issues around women's rights. I would like to see more work around that, you know, especially relating to the sexual freedoms, being able to say no and no meaning no. That would still help a lot.
Great, thank you. Kieran, do you have any thoughts?
Just really to echo what other people have said, I think it's targeting the right people and getting involved in the right services in particular areas, so that more people can get the message. So whether that's with church leaders or through the GP services as well, because one of the issues, I think, another area where people are being diagnosed is in the late presentation. So somebody who's diagnosed, who's probably had HIV for a long time and maybe don't fit into the normal criteria that we think about when it comes to, or don't appear to fit into that criteria of people who we think about who might be at risk of HIV, and therefore never get offered a test until it's too late. So I think it's making sure that we educate, and so educating GPs, educating the church leaders, so that more and more people can be offered testing, treatments as well.
Yeah, and that's some of the things that you was talking about yesterday in our meeting, Amy, around late diagnosis and how that impacts on different communities, and then on the treatment options, and then on people's life choices too. One of the things we're quite kind of interested in at the minute, we're really very interested in this whole notion of pre-exposure prophylaxis and PrEP, and how important it is for HIV prevention. One of the stark realities around PrEP is, a quarter of women in England, quarter of new HIV infections in England are amongst women. And in sub-Saharan Africa, that's probably more like 2/3 of new infections are amongst women. Yet in a resource-rich country like England, only a tiny proportion of women are on PrEP. And we think it's, going back to what you were saying, Clement, around things like negotiation and all of those sorts of things. We think PrEP gives a lot of power to a lot of women who are perhaps unable to negotiate condom use with a partner or with a customer. And we're really interested in how we can encourage more women to access PrEP. And I'm just curious, maybe first of all, from the clinicians, about what are women saying to you or not saying to you when you discuss PrEP with them. Kieran, do you want to pick that one?
Yeah, I think in my current role, that's not something that I'm coming across, because I'm dealing with people who are already HIV positive. But my previous role, I did work in sexual health. And I think one of the major issues, which I think Amy had already alluded to, was that PrEP is only really available through sexual health clinics. So, and I think in sexual health clinics, we're very good at identifying who may be at higher risk and offering PrEP accordingly. But obviously not everybody uses a sexual health clinic, and quite often may go to their GP when it comes to healthcare matters. And I think as PrEP is rolled out more, it would be so helpful if it was available through GP services or similar, so that more people are actually able to access it. Because there are so many women out there who are on contraception, get their contraception without any problems from the GP service, but actually might be at risk of not just pregnancy if they were to stop taking their contraception, but might be at risk of a HIV infection. And to be able to have that discussion either with one of the nurses or one of the doctors in the GP surgery, and then be offered a PrEP, would be a huge way of accessing those women who may be at higher risk.
Great. Amy?
Yes, I think it's our challenge, and as we said, Tom, our stretch target has to be, how do we, to all my colleagues today in the sexual health service, we've said our one task today is to have a conversation with a woman about PrEP. There is just something, isn't there, about us getting the message out there. I think we've all got a hell of a lot to deal with as ever. We've got a huge amount of demand, particularly coming out of COVID. For us also in sexual health services, monkeypox, or as we're now encouraged to call it, mpox, has had a huge impact as well on services, in addition to that post-COVID recovery in the last sort of 6 to 8 months. And I think now, as we emerge from that, and rightly prompted by World AIDS Day, Clement, but as you say, for that to be the start and not the end of it, is us saying, how do we, it really is a scandal, as Tom says, is right, that there is no local authority in the country apparently supplying more than 3 women with PrEP. And just to give you an example, in Leeds alone, we maybe have about 600 or so current users of PrEP, who will all therefore be male, apart from our 3 women. So it is scandalous that we haven't got that message out wider. I think we have to start absolutely with the women in front of us and having those conversations, or the women sitting next to us in our communities. And it is about us getting out that message then to the wider community, to our GP colleagues. As Kieran says, how do we nest it actually within female sexual health? I think we've established, and I think the community has established it very well as a part of LGBTQ health. But we need to nest it now, don't we? That as well as a woman, perhaps me thinking about my contraception, my cervical smear, do I need advice about pregnancy? Do I need any sexual health screening and PrEP? so we have to absolutely normalise it. I think nest it within those services. And make sure that both patients and providers are aware. And I think there will be movement, on how do we widen out that access as well. I think we've partly been guilty in services and always focusing on the highest risk because we're used to a bit of rationing and all the demands on treatment. But actually, we have to still achieve that groundswell of knowledge about PrEP, I think, and acceptance for perhaps those at highest risk to feel able to come forward. And knowledge is key, isn't it, there?
Yeah. Ben, do you have anything to add?
Sorry?
Do you have anything to add, Ben?
Not really. They have said everything, I think, yes. Yeah.
What about you, Clement?
I would add to that if you look at how governments, organizations, communities dealt with HIV, with COVID-19, the idea of sanitize your hands was almost everywhere. You go into a place, you still see a bottle of sanitizer, masks and gloves and things like that. That was a war room situation. You knew that if you did this, you had a contribution to make in the minimizing of the spread of COVID-19. And I'm saying to myself, why not the same with PrEP? Why can't we have it so available in all the critical places where somebody can walk in and know, at least I have a measure, a plan B or plan C or plan A that I can fall back on in case I'm exposed.
Mm.
I think I would love to see that kind of push in terms of PrEP. And I think, as Amy has said, the onus is really on councils as a matter of public health and promotion to come on board with that kind of drive.
I think you're absolutely right. I think we need to remember that we haven't had a national general public campaign around HIV since 1987, since the Tombstone campaign. And in a sense, I think we've had ones targeted at Black African communities and one at gay men, but not a general public one. And I think it probably will take something like that for us to get the message out more widely around PrEP. And that's hard. I think it's hard for us to think how we're going to do that, particularly when we're in the middle of a cost of living crisis as well. And, we do know that poor sexual health follows the fault lines of poverty very often. And but that might give us some opportunities, for example, about perhaps those doing some more outreach work to warm banks, those areas that are there to support people who are living in energy poverty. So I think we do, as a system, really need to think a bit more creatively about how we can get that message to about PrEP to those who would benefit from it, who aren't using it.
And what you are saying, can I say something?
Mm.
And what you all have said is crucial because since the COVID-19 has taken over, all these people living with HIV and AIDS are left behind, or let's say put aside. And particularly in our communities, if today you talk about HIV, somebody may reply. I remember we did that last year when we were talking about because on 1st of December, instead of talking only about AIDS, we were organizing workshops around health in general.
Mm-hmm.
So people were surprised to say, is HIV still around? they didn't think that for some of them it has been already deleted from the map. So it's now COVID, and then why are you talking about HIV? So I think that when what has been said is correct, we need to make sure that the message gets across.
And in one sense, we've been a victim of our success, haven't we? That you know, I remember when I was a 20-year-old young gay man who HIV was just central in my life. It was, I thought about it daily. Young gay men aren't thinking about HIV daily these days, and that, in a sense, is a great success. But also, you know, it does mean it gives our job a little bit harder in terms of making it a higher priority for some folk. Yeah. So while we're talking about success, and maybe to wrap up, thinking about the past 40 years, if you could pinpoint one thing, either personally or professionally, or globally, that has been a success, what would that be? And I will start with Amy, because you're very good at this sort of thing.
Oh my God. No pressure, folks. Okay, I think in a sense we've talked a little bit about some of the fantastic developments in treatment, whilst not being still a bed of roses to have HIV and live and deal with it every day, and the commitment that's needed to keep taking those treatments. And I think I am so inspired by our patients and the people who are doing exactly that every day, in looking particularly after our young people and our people under 25 who are growing up with HIV. So these are young people born with HIV. What I am still taken aback with is, I think, what you've also said about the crossover into poverty, and a fancy word, that intersectionality, Tom. And I've written a long submission to the parliamentary group looking into this on behalf of our young people to say, why do we still have so many young people not only growing up with HIV and trying to deal with that and the impact that has on their budding relationships, trying to have families, find their way in the world, but are they also having to deal with not being in education or training, having not only fuel poverty, but real markers of deprivation, potentially losing one or both parents and trying to forge their way in the world, and having to deal with so many crossover social difficulties, which can make it so difficult for them to even begin to engage with their health, never mind with a stigmatized condition like HIV, that it so often still is. And I think I am inspired and incredibly hopeful that we have a positive message to give those young people now about lifelong treatment, normal life expectancy, hopefully a future of something injectable and easy, that their babies born, that they can expect for those babies to be negative, and that they can be suppressed on treatment and have a normal, we hope, and happy and healthy sex life with their partner, whether they're positive or negative. So that's fantastic. But at the same time, that allyship that you mentioned, I think for us, is still so vital to cross over into that social sphere and combat still the stigma and the social difficulties that many of our patients are dealing with, that absolutely hampers their ability to even get to health. And I think that's my challenge, if you like, my dual challenge as an HIV clinician.
Great, thank you. That's great. Clement?
Thank you. I think over the years, the past 40 years or so, looking back brings memories of people that we have lost to HIV/AIDS, and that brings a tinge of sadness, really, when I think of those people. Friends, relatives, colleagues, people that I've known for quite some time. And sometimes I think about it as lives that really shouldn't have been lost. But I'm also thinking much more positively about those many people who are now able to live normal lives. And as we begin to experience these improvements in medication, in treatments, in drugs, we have that assurance that lives will continue being saved with the treatments, but also with the right messaging. It's sad, I think, in the UK that we can still talk about health inequalities affecting minority groups, affecting certain groups, And I think that is a shame, really. In Africa, the health inequalities are much more pronounced because of the poverty levels, the deprivation, and in some cases, the lack of knowledge around the many strides that have been made in HIV/AIDS. I would like to see the allies coming on more strongly. I think there's a greater role to play for the allies, and maybe this is one of the things that will bring that game changer, so to speak, in the advancements of treatments, in advancements of better policies from governments, and in terms of dealing with that stigma that still remains in some of our communities. It is still a problem, that stigma, because we in the churches are not really dealing with it as we should. And when we're silent about it, we perpetuate that stigma, and we need to deal with that. Thank you.
Thank you, Clement. That's lovely. Kieran.
I think for me, it's coming from where we were when I first started in HIV, and where there wasn't much treatment available. So now we're in the position where we're actually talking about by the year 2030 having no new diagnoses, that we're actually even able to talk that might be something that happens with the UNAIDS sort of 90-90-90 targets, which are like in lots of countries are now 95-95-95, which is sort of 90% of people with HIV being diagnosed, of those 90% of people being on treatment, and of those on treatment 90% being undetectable. That, if we can achieve those or increase it to 95, actually by the year 2030 is very hopeful that there's not going to be any new infections. And I just think that's amazing that we're getting there. And it is going to take a big push to get there. We do need everybody to work together. We need those allies out there as well to get to that point. But I think that would be a lovely end to my career, I think, in 2030.
Yeah. Ben.
Yeah, when we talk success in conflict resolution, we do always say you have to look at also to the negative aspects. The success for what has been the success in the last 40 years, many have said it already, the treatment is really the first one. But the negative aspects also have been the people, although people live longer than before, those who had the disease, and because now they are looked after, they can live longer. But the negative aspect is that people slowly don't care. They like before. They think that now, yes, we have a medication, although it's not helping 100%, but that brings people to be a bit slow in being careful. So that is something where we have to say strongly that being careful is the key. Yeah, particularly in these terms of sexual health.
You certainly can't take a foot off the accelerator on prevention. I think that's very true. I think for me, one of the big battles we've still got to fight is stigma around HIV, and that prevents people from getting tested, so that prevents people getting on treatment, and not prevents the prevention message getting across. So I think the success around that, and one of the greatest things, has been U equals U, the undetectable equals untransmissible, and the weight that seems to have been taken off a lot of people living with HIV's shoulders in terms of their sex lives and their lives generally, has just been transformative for so many people. So that would be, I think, my highlight. Well, that's our time up. I'd really like to thank you all again, to Kieran, Amy, Ben, and Clement for joining us today, and for everyone who's watching today, thank you for tuning in. And this video will be available on our YouTube and other social media sites for those folks who want to see it later too. So thank you very much, everyone. Bye-bye.
Thank you. Thanks. Bye-bye.
Bye-bye. Bye.
Bye.